Good afternoon and welcome to this afternoon's meeting of the North Carolina State Transformation Collaborative, where we're getting together for our shared purpose of advancing whole person health in North Carolina through shared and collaborative action. I'm Mark McClellan, the director of the Duke-Margolis Institute of Health Policy. On behalf of the Institute and all of the groups that have come together to make this STC possible, I'd like to welcome those of you here who are joining us in person in the room and the people who are joining us online from all across the state and perhaps elsewhere too, as well as our federal partners in this effort at the Center for Medicare and Medicaid, CMMI, Center for Medicare and Medicaid Innovation, and hear from them in a little bit. We go to the next slide, just a few logistics before we get going. If you want more information on the alignment proposal for the North Carolina State Transformation Collaborative that we're going to be discussing here today, that's that QR code there on the left of the screen. If you want more information about the panelists, the speakers, their bios, who you're hearing from today, that's the other QR code on the right slide. In the next slide, we are going to try to make this as interactive as possible with people in the room and everyone who's with us online. So if you want to help us get started, take a look at that Slido QR code on the screen, take a picture of it, and that will take you to a place where you can enter information, answer questions, interactive questions that we're going to have during the course of the day. And we'll start out with the next one, or the first one, which is on the next slide. What types of organizations or perspectives are represented in today's audience? So we see we've gone from 2 to 4 to 5 respondents. And those of you who are online, feel free to join in as well. We've got a diversity of perspectives, including people from our federal and state programs, people working in different parts of the healthcare sector, providers, integrated plan perspectives, state and federal, and independent experts and other stakeholders too. So it's really good to see the diversity of perspectives who are coming together, and that's really what the STC is all about. So thank you all for getting engaged early, and I hope you'll stay engaged through Slido and the discussions to come. On the next slide, I just wanted to, again, continue my welcome and run through the agenda for the day. So we're starting with the welcome and some of our goals for the day. And just to reiterate there, our purpose here is to help advance the shared goals of improving population health, affordability, patient experience, reducing disparities in healthcare, relieving provider burdens. All of those things are not easy to achieve. We do know we weren't getting there in the old way when we were fee-for-service payments and kind of traditional way of delivering care. This state has taken a lot of steps to lead the way towards advancing better models of care that are explicitly about paying for and establishing supports and institutions and infrastructure to achieve these goals together. And the STC, I think you can view as a collaborative mechanism to help make that happen. Just as when we were talking about fee-for-service payments, everybody had to use the same ICD-10 codes and CPT codes for billing. We're trying to get the infrastructure right for moving to care that's about people and whole person health. And that takes a different kind of infrastructure. In some ways, it's more complex, but the goals and the opportunities here are far greater. And so that's what we want to talk about today. So we're going to talk first, hear from the leadership at the Department of Health and Human Services. Has been playing an integral role in moving this work forward. And we'll hear about some of the work of the State Transformation Collaborative to date from Dr. Rebecca Whitaker, who's been coordinating this effort here at Duke-Margolis. Then our first panel will review where we are, what kind of progress have we made, what does this new alignment proposal recently released for the State Transformation Collaborative mean for advancing these shared goals? And then we want to look ahead with a focus on what has been a priority for everyone involved in the State Transformation Collaborative, and that's identifying some practical steps, measurable steps that can be taken to reduce the disparities in health that are an important part of the overall goal of our work in health reform together. We'll have some discussion about that as well. We'll hear from some of the leadership in these partnerships, federal state programs at the Center for Medicare and Medicaid Innovation. We'll review what happened and talk about some next steps. And hopefully you'll come away from this meeting with a better idea of what's going on with the STC, and we'll all collectively come away with some better ideas on how we can work together to achieve these goals. So moving on to the next slide, just a reminder that while we are talking about alignment here, that means using evidence, using experience, shared measures, diverse perspectives to figure out better ways to make it possible to impact the delivery of healthcare, to improve value in care. So these are measures, they're data concepts, there's exchange of evidence, all of which we want to make available to the public and any and all interested stakeholders, as well as the state, to help achieve these goals of improving care, advancing whole person care, reducing complexity for clinicians, those goals that I talked about before. In the course of doing this, we go on to the next slide. We want to make clear that we want to avoid certain topics. This is about advancing shared goals, advancing competition in support of those goals, not addressing or not running afoul of antitrust concerns. So basically, don't talk about non-public, proprietary, sensitive information here. Do talk about what available information there is to help advance these efforts. Talk about what kinds of standards related to whole person health and costs and quality of care and burden could help advance our goals, and the supporting resources and educational needs to advance these goals as well. And let us know if you have any concerns about any of these issues. And on to the next slide. Just wanted to orient again about the importance of this work in the context of the leadership happening in this state in moving towards more advanced whole person care by investing in health, by not only changing the way we pay, that's a means to an end, but by focusing on this intentional goal of whole person care that improves outcomes, that reduces costs and reduces burden. There are many examples of how this is playing out in state health reform, including the Medicaid transformation that has been the foundation of Medicaid expansion in North Carolina, investments in behavioral health, especially around making it more accessible, convenient, integrated into primary care, strengthening primary care through the Making Care Primary initiative, which we'll talk more about today, and of course the work of the State Transformation Collaborative itself as part of these efforts. On the next slide, this is an initiative that has gotten national recognition. North Carolina was selected as one of 4 states to participate in the Healthcare Payment Learning and Action Network State Transformation Collaborative. This is a national CMMI-supported public-private collaboration to find the best ways to advance the goals of whole person health and do it effectively together. This slide talks about what the state transformation collaboratives are. Again, it's trying to bring together all stakeholders who care about these issues to work on common challenges, such as around common measures or data standards or other issues that can get in the way of making progress towards achieving the goals of whole person affordable care that addresses health disparities. 3 other states, as noted here. North Carolina is a key part of providing examples that can be used nationally to advance these same goals throughout the U.S. healthcare system. And on to the next slide. These are foundational steps, very important for achieving progress on our overall key goals. So the North Carolina State Transformation Collaborative aims to align with some of the national efforts, as I just was discussing. We are working with the state of North Carolina, DHHS, with Duke-Margolis serving as the neutral convener for this multi-stakeholder effort with support from CMS and CMMI, as I mentioned, again, working on these shared challenges that we can overcome more effectively together than trying to handle them all alone. And we are taking these steps now to make it easier to move into whole person care that is more affordable, more accessible, and less burdensome, consistent with the goals of transformation, healthcare transformation in the state. So brings me to the meeting purpose, I think on the next slide, which is to help us achieve some of these goals. Some of the things we're going to talk about today: aligning quality measures, data sharing and infrastructure, improving data quality. Probably not the issues that keep most of you up at night or they're thinking about when you go home. But if you do think about it, I mean, these are the infrastructure, the component where that is needed for a healthcare system that focuses on investing in health and delivering value as opposed to just delivering services. So this is what is going to get us to our goals of improving patient experience, outcomes, affordability and costs, reducing provider burdens, and reducing health disparities and advancing population health. So next slide is a little bit more information about the collaboration with the national efforts, what we're doing here around measure alignment, around data sharing, and getting data that helps us understand differences across racial, ethnic, sociodemographic, and socioeconomic groups in terms of the quality of care received, the outcomes and access. Those are all part of national efforts where a partnership, we think, between states like ours that are trying to lead the way on this and federal efforts around such topics as standards for data exchange, the Trusted Exchange Framework and Common Agreement, TEFCA. It's a mouthful, but that's intended to be national standards to make it easy to share data that's needed for improving care and to, without burden on healthcare providers, track how we're doing and help support and reinforce the most effective efforts. So it's a state collaboration that's guiding and working together with making national progress on these issues. And the next slide, just a few last words about the meeting purpose. Our shared goals, as we've talked about, are what we want to catch people up on today. We're going to talk about the alignment proposal for the North Carolina State Transformation Collaborative and get feedback from our panelists, from hopefully all of you, on how we're doing. Do these seem like the right directions? What are the questions? What are the ways to improve on these efforts to lay and continue to strengthen the foundation for collaboration and work together on these shared goals of advancing whole person care in North Carolina? This has been a very much a team effort, public and private, from all across the state. I think on the next slide shows some of the organizations that have been participating in these efforts. We want to thank everyone. These public-private collaborations are not easy to maintain. They depend on the commitment and the recognition of the shared goals we have and the contributions that we can each make to getting there better and faster together. So we're going to try and build on that work today, but it's a strong foundation thanks to this wide range of committed organizations who have helped us get to where we are now and want to make more progress on the goals. So with that as an introduction, I would like to turn to the next item on our agenda. We're very pleased to welcome Dr. Betsy Tilson, who's the State Health Director and Chief Medical Officer at the North Carolina Department of Health and Human Services, who's going to give us some updates on what's going on at DHHS related to the goals of healthcare transformation and the related supports for this multi-stakeholder collaboration in advancing health and well-being in North Carolina. So Betsy, please come on up.
I only have 10 minutes, so I promise you I'm not going to update you on everything going on in the HHS, because you can imagine there is a lot.
And are you, if you're not mic'd, we do need you to probably talk into the... Right.
Oh, heck.
Or you can just.
I'm gonna do it like this,
Yeah.
but I am known to talk with my hands, so when I wave them around, let me know. And I will try to reel that in. But I'm so grateful to be here. Seeing so many familiar faces, so many old friends, you know you're in the right place when you get about 6 hugs on your way in. So grateful. And I think that is such a hallmark of North Carolina that we've really, our partnership and longstanding partnership is just makes us so strong. It's an amazing place to be, which I think is why we've been able to be at the national forefront in so many of this, because we have those relationships, we have that trust, and we can all work together. So really grateful for that. And I'm really honored to speak on behalf of the Department of Health and Human Services. This work is fundamental to what we do, and you'll be hearing from leaders across the department who are really going to drill down into a lot of the work that we do, because this is really fundamental and exceedingly important to us, not just as a department, but also exceedingly important to us as a state. If we really want to think about being serious about improving the health of North Carolinians and ensuring everybody has the opportunity for health, this is the work that we have to do, and we have to do it together and in partnership. And so I think there's no better place in North Carolina, resting on our history of collaboration and moving forward. It's just critical work, and we are fully in line and excited about it, and really grateful to the partnership with the Duke-Margolis Center to be able to do this as well. So the public-private partnerships we love and we're excited about. I'm thinking through some of these foundational elements that Mark talked about. One, thinking about addressing whole person health. That means physical health, that means behavioral health, it also means social health, and addressing all those factors that influence someone's health outside of the clinical wall. And I intentionally use the word whole person health, not whole patient health, because as you all know, we're a patient, 0.1% of the time, we're a person all the time. And we think about all of those influences in our environment that influence our health all day, every day. We have to think about that person outside those clinical walls, really important. Thinking about alignment, we talked about measures, payment structures, so that we are decreasing that burden on the provider level. Thinking about enhancing our data infrastructure. Sam's going to talk a lot about that. And how can we use our data infrastructure as not a barrier, but as a tool to drive efficiency and decrease burden. And then thinking about using the data that we have to really drive programs and decrease disparities. And I think Emma's going to talk about that as well. Oh, and Kristen will talk about our alignment for payment measures and payment strategies as well. So really excited about that. And then all very much ensure we're strengthening our foundational care delivery system, which is our primary care system as well, and making sure we're really investing in primary care if we want this to work. So let me just add a little bit more context of how this work fits into work that's going on at the state and tee up some of the conversations that you'll hear in the panels. So one, I think this work dovetails beautifully into our work of Healthy North Carolina 2030. And this is, we set 10-year goals to how we want to improve the health of the state. And then we have our state health improvement plans that we put out typically yearly. COVID, we took a little pass on 1 year, but yearly, to really say, how are we going to move forward on these, what we call 21 wicked problems, these health indicators that are so hard to move, but we can move them if we do it in partnership, if we do an alignment, if we do our stakeholders. So this fits in beautifully to that. So if you're not familiar with that Healthy North Carolina 2030 and our statewide measures and goals, I would encourage you to look at that and figure out how can we fit in. And then there's a lot of things going on at DHHS, some that we are leading, some that we're partnering, some that we're supporting, but that really fits into this work. So first, thinking about addressing whole person health, and again, physical, behavioral health, and social health. One of the most important levers, a foundational lever, is improving access to care. And as Mark said, Medicaid expansion, which was 10 years in the making, finally got that done December 1st. Huge foundational lever. And as of this morning, we launched December 1st. Our 2-year goal was to enroll 600,000 people. That's what we estimated would be eligible. As of this morning, we are 458,322 people. So we're amazing. So not even quite 6 months, we are almost at our 2-year goal. And I have to say, the work of the Medicaid team and making this seamless behind the scenes, all the implementation work, it is amazing, as well as our really robust community partner work, especially out of our Office of Health Equity, in really engaging our partners to make this happen the best in the country, by far the best in the country has been our Medicaid expansion. So we're so excited. Second, thinking about behavioral health, for historic investments in behavioral health. Last General Assembly, we $835 million invested in behavioral health. Huge, transformational. And also thinking about how do we integrate physical health and behavioral health in the practice setting. So collaborative care, which is not just Medicaid, but also multi-payer, so that our practices can have multi-payer support for that collaborative care. So lots of work around trying to integrate behavioral health into physical health and access to care. And then the work around social drivers, which I will say is one of my favorites, but really addressing all those non-medical social drivers. So food insecurity, housing insecurity, interpersonal violence, transportation, all those things that gets in the way of good health. So doing a lot of work around that, trying to lay some foundational infrastructure and tools that can be used across populations, across payers, things like our standardized screening questions, those health resource, health-related social needs. That's now what HRSN. Anyways, asking about food and housing. And so thinking about that standardized, the NC Care 360, that once you identify a need, how can we refer them? Thinking about what's the right workforce, like our community health workers, beautiful work, complementary or workforce to help address some of these. And then levers that we've pulled in Medicaid that where we control. So things that we've put in with our plans to, I don't like to say the word incentivize because I think our plans want to do this, but we got out of the way and we made it easier for our plans to be able to invest in the things that they want to invest in, thinking like, what's the definition of the numerator of the MLR? How do we think about community investment and give our plans credit for that? And then of course, our 1115 waiver, where we're truly buying health with Medicaid dollars, and we can use Medicaid dollars to pay for food and housing and transportation and interpersonal violence. We had Shep Center is our independent evaluator, and we had our most recent evaluation results, well, a month ago now, 3 weeks, a month ago, that showed lowering your social needs. People that are enrolled, their social need goes down, ED utilization goes down, hospitalization goes down, and $85 per member per month healthcare dollar savings. That is huge in the healthcare world. We're so excited that we're truly buying health and show. We all knew this, and now we can actually show that it is working. So excited about that. And we have our new 1115 waiver proposal at CMS now in negotiation, hoping to go statewide with that and tweak some of the services, things that we have learned. So really excited about that. Next piece, thinking about aligning our measures and our payment structures, and especially as we're supporting primary care, and that Kristen's going to talk a lot more about that, but we had our primary care task force. That report got submitted to the General Assembly to really talk about the importance of investing in primary care. We're working with the CMI Making Care Primary model as well, so we can help integrate those measures at the practice level so our providers don't have a different measure set for every different payer. So really trying to think through how do we align and support our providers. Investing in that data infrastructure to make it more efficient. Sam's going to talk more about this. How do we use the HIE for some of those nuts and bolts things every day, so that you're not, if you're putting your vaccine records into our North Carolina immunization registry, you're not double entering. How do we make that alignment? How do we make it easier for you to do electronic lab reporting for your public health reportable diseases? How do we make it easier for you to electronically order the state lab? Just some of that bread and butter stuff to make it easy. Also thinking about data sharing. So how about those, and I see Jesse, all those social risk needs screenings you're doing, how can we have that move from provider to provider so a person isn't being screened all the time? And then thinking about digital quality measures. I'm actually really, it's so wonky, but I'm really excited about this, and Sam's going to talk about that. But that instead of having providers have to report their quality measures, what can we capture digitally, and then also have it consistent across our plans so that providers can actually concentrate on improving quality of care and responding to those care gaps instead of all the administrative burden they have to do to report to the plan. So much promise in this. And finally, and certainly, no, not almost finally, penultimate, is using all this data and all this infrastructure to really decrease our disparities. It's not good enough to improve the health, but we want to improve the health of everybody. And that means seeing the disparities, knowing where the disparities are, using our data, and then how do we lower those disparities? And Emma's going to talk a lot about that. North Carolina, especially in our Medicaid program, we are a leader in having granularity and richness of our data, looking at race, ethnicity, granular of that data that helps us then understand where are those disparities. And then we can use that data and our initiatives, our quality measures, our financial levers to drive that. For example, thinking about how do we lower disparities in childhood immunization rates. So making sure all of our kids are being protected from life-threatening diseases. So excited about that. Emma's going to talk more about that. And then finally, and certainly not last, we have a lot of people in this room, which is great. We have to do this in partnership. But we also have to remember the other people in the room are the people we're actually trying to serve. The people who are on the other end of our programs, of our policies, of our clinical care, having that voice of people we serve at the table with us, informing us, making sure we do a better job, and informing our policies, informing our decision-making. We're being very, very, very intentional to be sure we're having the voice of people with us. And so I would charge us all to think through that. How do we ensure that the people that we're actually trying to serve have a voice in this? And by doing all those things, and all sorts of things already happening and even more, I just think that the future for North Carolina is great. Not just North Carolina, but we continue to be this national leader in how you do it and how you do it together, and how you do it well. So with that, and I was right on time, wasn't I? I'm turning it over to somebody, but I don't know who. So maybe, okay, great. So thank you.
All right. Thank you so much, Dr. Tilton. I'm going to try and mimic your style here and hold the mic. But thanks everyone for joining us this afternoon and for this discussion. My charge for the next 10 minutes or so is to highlight how the North Carolina STC, or State Transformation Collaborative, has evolved over the past year, and share a summary of the alignment proposal that we released prior to this event that will really tee up our first panel discussion for today. So if we go on to the next slide, this is to kind of give you a sense of where we've been and where we're heading. Many of you may have attended our last big meeting in February of 2023, where we launched the North Carolina State Transformation Collaborative and solicited feedback on shared goals and priority strategies that we identified through convenings and work groups and learning calls with a variety of healthcare stakeholders that you saw showcased on that slide earlier. So since its launch in 2023, the North Carolina STC has continued to convene stakeholders and work to identify action areas that can advance these shared goals and support primary care advancement. And we've compiled all of this, again, into this alignment proposal. From here, we are going to integrate feedback that we hear today, along with future engagement sessions with you all to develop an implementation and evaluation plan for the North Carolina State Transformation Collaborative to make sure we're measuring and tracking progress on the goals and strategies that we set out to accomplish. So on the next slide, I want to just quickly touch on the purpose for the alignment proposal for the North Carolina State Transformation Collaborative. So what we're hoping to achieve through this proposal. One, certainly to document the work that we've completed to date on the STC goals and kind of making progress toward those goals for the North Carolina STC, again, which are improving population health, improving the patient and provider experience, advancing health equity, and reducing cost. In the alignment proposal, we also want to outline a set of preliminary action areas that are designed to accelerate measure alignment, data sharing, and health equity data improvements that we can really use to measure and track disparities in our state. And finally, to establish a foundation that will really lay a pathway for ongoing alignment and innovation in the long term so that we continue to work toward that goal of equitable and high quality whole person care. What is contained in the alignment proposal is really driven from key challenges that we heard from all of you with respect to implementing whole person care and implementing payment and care delivery reforms. Some of those key challenges are highlighted in this kind of circle on the left-hand side of the slide, but really tie back to different sources of administrative burden. We heard a lot about variability in measures, including in payer and provider contracts, certainly variability in not just the measures themselves, but how those measures are implemented. A lack of a consistent way to define and measure disparities, which is preventing apples to apples comparisons, both within organizations, but also across organizations. And finally, limitations in data interoperability as a result of some of this variation in measurement, collection, and reporting. So from these challenges, we sought to identify opportunities and action areas, what we're calling them in the alignment proposal, to better reduce burden and enable this movement toward whole person care. So on the next slide, you'll see sort of both how we're operationalizing the key strategies for the North Carolina State Transformation Collaborative to advance multi-stakeholder alignment, but also kind of this sort of summarizes, encapsulates the alignment proposal itself. So across the top here, you see the 3 priority strategies for the State Transformation Collaborative: aligning on quality measures, improving data infrastructure, and enhancing health equity data. Across the middle is sort of a high-level summary of the action areas. And then on the bottom, acknowledging the different advisory groups that we're convening to help shape this work. And all of this is in service of promoting advanced coordinated care models and really starting with a focus on primary care. So I'm going to talk through each of these different strategy areas and the proposed action areas on the next few slides, starting with our first strategy around aligning quality measures. So I think folks are well familiar in both in North Carolina and also across the country. States have tried to align on quality measures across payer contracts and lines of business. This is hard work, and I think we see different levels of success. And so what we are really prioritizing through this North Carolina State Transformation Collaborative is actually drilling down on the implementation of the measures themselves, and trying to reduce the burden associated with the collection and reporting of measures in payer and provider contracts. So we are proposing to start with 3 key measures: child immunization status, controlling high blood pressure, and hemoglobin A1C control. And again, from here, using these measures to identify how can we reduce the burden in the collection reporting of these measures by identifying some multi-stakeholder alignment strategies. We are putting these measures forward because we know that they are common across value-based payment contracts in public and private payer organizations. They are clinically significant. They're historically pretty challenging to collect and report on, and they're also associated with persistent disparities in our state. So we're proposing to start with these measures, and then if we go on to the next slide where we outline our second strategy to improve data sharing infrastructure, kind of taking those measures as a use case and saying, okay, what are some specific things we can do to leverage automated reporting tools and streamline the collection of those data to make life easier for provider organizations and payer organizations alike. So what are those specific strategies that we can apply to improve the data sharing infrastructure? On the next slide, and I'm not going to go through this in great detail, but just want to highlight the specific action areas included in the alignment proposal, addressing both short-term and long-term actions. The intent here is to kind of put out a vision for a robust data sharing ecosystem in North Carolina, while also acknowledging sort of the range of readiness, if you will, among provider organizations. Not everybody's ready to go fast and implement, national data interoperability standards. So what can we be doing to kind of help all organizations move along this spectrum? And I want to just highlight 3 quick archetypes to kind of illustrate this. In some of the conversations that we've had, we heard from some primary care organizations that they are not able to participate meaningfully in value-based care contracts because they don't have the resources or the bandwidth to do all the supplemental data feeds to payers. So, they're not even participating in, meaningfully. So what can we do to help those organizations? There are organizations who reflected on, we spend so much time collecting the data and moving it from point A to point B to point C that we're not actually able to use the data to drive clinical improvement or population health improvement. So what can we be doing to help those organizations? And then finally, organizations that may have more capacity and bandwidth to adopt and implement those national interoperability standards, submitting electronic clinical quality data, leveraging bulk FHIR, for example, but may not have the use case or the incentives to really apply those things now. And so trying to identify both short and long-term strategy or action areas that would address kind of each one of those archetypes. And then finally, our third action area related to enhancing health equity data. If we go to the next slide, we know that there are persistent disparities in health outcomes across the healthcare system. And we also know that there's pretty significant variation in how organizations collect, share, and use health equity data. And by health equity data, we mean things like race, ethnicity, language data, disability status, sexual orientation, gender identity, et cetera. But this variation in the collection, sharing, and use of health equity data makes it challenging to address observed disparities. So we are going to be convening a health equity data work group later this summer that will aim to accomplish a few things. One, identifying some leading practices in the collection, sharing, and use of health equity data. Establishing some principles for how to guide that work, because we know it's really important to build trust and work with communities and people that experience in this process, as well as explore standardization across organizations and how we are collecting, sharing, and using these data. And so I think the next slide here, yes. So to recap, North Carolina healthcare leaders need help streamlining how health reform programs are implemented in order to support the healthcare and social service system capacity to provide whole person care, reduce time spent by providers on administrative tasks so they can focus on providing the best care for patients, and measuring the state's progress toward these health reform goals. So the collaboration established through the North Carolina State Transformation Collaborative, the action areas outlined in the alignment proposal can provide really a starting point for ongoing alignment and innovation. It's going to require, ongoing stakeholder engagement at both the state and the national levels to advance these shared goals and ultimately work toward implementation. So we really want to hear your feedback on what we've just highlighted, and I'm excited to introduce our first panel, who's really going to kick off this discussion. So I'm going to ask Mark to come back up to the stage while I introduce our panelists. So Dr. Michelle Buckner is the Regional Chief Medical Officer for Aetna Better Health. Kristen Dubé is the Chief of Population Health at North Carolina Medicaid. Yes, you guys can make your way up. Dr. Angelo Sinopoli is the Executive Vice President of Value-Based Care at Cone Health. And Sam Thompson, who is the Executive Director at the North Carolina Health Information Exchange Authority. So we're excited you all are joining us today. And Sam, I know you have a hard stop, so feel free to cut and run whenever you need to.
That's right. But first, thanks, Rebecca, for that overview of the alignment. So we're going to pick right up with this panel where Rebecca left off on how these different individuals who are with me today bring some distinct and important perspectives to the alignment proposal and these related goals. Have thought about it and where they're thinking about going from here. So wanted to start with maybe just going down the row, and then Sam, I'm going to give you a follow-up question soon as we want to, I know you're a double book.
Y'all are my first priority.
Yeah, popular, data is important, right? We've talked about the whole person strategy and the goal of improving outcomes, experience, spending, provider experience as well. I'm wondering if you could each say just a few words about what you see as some of the biggest challenges in moving forward, and how the strategies that we've just been talking about today in the alignment proposal and in this overall state transformation collaborative effort can help address those challenges. So start right there with you, Michelle.
Okay. Good afternoon, everyone. So specifically, the biggest barrier I see here is the time it's going to take us to get this launched. So we heard a lot about provider administrative burden, relieving that burden so people can focus on the whole person. From my perspective, the level of provider burnout we have and we experience now in primary care is at a level that if we don't do this soon, I'm concerned that we won't actually have a workforce. And so it's part of the reason I've seen transformation in provider institutions when there is, a full risk capitated model where you have full control. And I think being on this path of aligning so that we can move forward in the same direction is really important.
Thank you. So, I know you've thought about this a lot too, including the provider burnout issues.
Yes, I'll take a different, since you've covered that one, I think that one is a big issue as well, but I think I'll take it from the member perspective and really around member participation. So we at North Carolina Medicaid have rolled out a lot of new programs over the past several years. How do we make sure that members are participating, and how do we make sure different populations of our members are participating? So making sure we have effective health equity data to be able to analyze the impact of our programs, identify where there may be disparities in uptake, so we can really think about when we're targeting and making adjustments to our programs, we're really reducing the disparity in access and outcomes that are coming from the programs we're implementing.
So I'm new in my role, and so my perspective has changed recently. So at the Health Information Exchange, I think I knew this when I was at Medicaid, but there's just one solution does not seem to fit more than one provider. They're all very different, whether that's across provider types. Behavioral health providers need very different things than primary care providers, or across, a lot of what we're concerned with is electronic health records. So if you're on Epic and you can pop into care everywhere, it's a very different experience than if you are at a skilled nursing facility and need to look at your patient's data across systems. And so, what I want to, go into a room and say, look, we're doing this and it'll make your life easier. And maybe for a quarter of people it does. And for the rest of the people in the room, a different solution is required. So I think hearing that voice of the provider and what their experience is, in my case, using our tool and what we need to do differently to meet them where they are.
Angela?
Thank you, sir. Can you hear me? I agree with everything that's been said, and I think some of the things that contribute to that is the biggest barrier that I see in the work I've done is the complexity of all the work that we need to do. So if we're really going to address improved outcomes in our patients, and we're really going to get down to improving health equity in our community, the complexity of that is really enormous. It's not just seeing a patient in an office and fixing a gap in care. How do we collect the right kind of data so we can risk stratify our patients, but also risk stratify our community? How do we know what the deficits in our communities are that we can create programs around to address those kind of deficits? And so that complexity, particularly as a practicing doc, is overwhelming. And so how do you really affect broad populations of patients and not just a single individual patient one at a time?
Yeah, and I want to go back to Sam, both because you're time constrained, but also because these data issues are so important, like you were saying, for supporting healthcare providers. Part of the burden of moving to value-based care, especially if we don't move overnight to capitation or something like that, as you were saying, is that from a provider perspective, you're still doing some of the fee-for-service, a lot of fee-for-service billing, and on top of that, starting to get reports in on how to improve care. And on top of that, to Angela's point, if you don't know where you are, if you don't have good situational awareness data, which don't come just from your own practice, it's really hard to figure out how to improve. So maybe Sam and Kristen, if you could talk a little bit more about what the Health Information Exchange Authority and Medicaid are doing to try to make this whole data sharing and data alignment standardization process easier to at least get us towards some of the most important, early steps in Angelo's overview, that this is a complex system, but we do want to start making some visible progress, including on provider burden soon.
I'll let you take it.
Okay. So for those that I'm not working close with already, so I was at Medicaid until about 3 months ago, and I think laid a lot of the groundwork. And I was with the Division of Public Health before I was with Medicaid, and the reason why I'm so excited to be at the Health Information Exchange is I felt like so many of our conversations about quality and population health sort of led back to, well, if we just had a centralized place where everybody could access the data, and we had high quality data from everybody's EHRs, and it could be shared. And so it would lead to the Health Information Exchange with the big but of if it was a fully realized Health Information Exchange. And so I think a lot of what we were planning at Medicaid, and we're still planning now with the support of CMS, is those kind of solutions that put that make the fractured environment that managed care created sort of coalesce back together in decentralized place. So a lot of that is related to quality measurement. So instead of having each health plan sort of run independent quality measures, submit independent gap reports, and extract, maybe the biggest of all in terms of burden for providers, extract clinical data one by one from providers, each in a different format. Try and sort of push Medicaid, push the health plans to using a centralized aggregator where providers already have to submit their clinical data, where they already have to go to look at their performance, right? And use that as a venue to present a unified front for the Medicaid side, instead of working with, half dozen different health plans as tailored plans come online, as the children's healthcare specialty plan for foster children comes online. The environment only gets more complex. So the hope is that the HIA can make it less complex. We're doing similar work with social determinants of health data, because we know those are aggregating in EHRs and not making the health plans, whereas the health plans are collecting data and it's not making the providers. And human service organizations are collecting the data, it's not making it everybody else. So the idea is, again, do the same idea of what everybody wants to do in health policy, but kind of make it simpler and more centralized.
And Kristen, Sam was at Medicaid. You're still there overseeing these population health programs. And as Sam was talking about the data standards and standard ways of exchanging data, that's also lining up with what you're doing on measures, right? To get to common measures that can fit with those data flows.
Yeah, no, absolutely. So we have a data strategy we developed in advance of going live with Medicaid managed care. And as we're reviewing and looking at the results of that data strategy and updating measures as we look at that, I think, what comes in is we see that the data are not as clean as we expect all the time, right? Because we have this very complex system. Oh, I heard a few laughs from the audience. Really. So as providers are frustrated, we are also frustrated, right? Because we really want to be focusing on what moves the needle for these members and really better health outcomes. And then when we have these challenges with the data, it delays us, it delays our efforts. So we're really excited to be working on this with the North Carolina Health Information Exchange and all the work that was laid before that with Sam and his team. So that's fantastic. We'll continue to work on that. And that's also serving as the foundation of a lot of the work we'll be doing with the Making Care Primary. And I don't know if you want to touch on that already, but we actually posted a provider bulletin yesterday. I don't know that our communications announcement has gone out yet. But we are going to be seeking feedback from providers and payers from the community generally around our approach at Medicaid for aligning with the Medicare Making Care Primary model, which is rolling out in North Carolina. We're really looking at getting input on the design. We're thinking about a standard value-based arrangement that we would have all Medicaid health plans, at least starting with the standard plans, implement, and really aligning that work with the Medicare model. So as you know, 2 of the 3 measures mentioned earlier by Rebecca are part of also the Medicare Making Care Primary model. So really thinking about how do we align the work we're trying to do, and really thinking about this, how do we incentivize, how do we develop this program so providers want to participate and see it as an opportunity to reduce provider burden in their payer contracts and in their kind of approach to focusing on incentives and quality improvement across more of their payer contract arrangements.
And you talk about the steps that you're taking at the state level now towards alignment. I guess I would add to that there's a CMS component of this too, where the Making Care Primary Medicare version will be rolling out next year. So for the providers who aren't already in one of these advanced primary care contracts for the Medicare beneficiaries, that's a chance for further alignment with work to get with CMS, get the same aligned measures there, data standards and so forth. And then looking ahead on additional measures, there's a national CMS quality measurement strategy that this state transformation collaborative and DHHS are very much working with the federal government on trying to, again, minimize burdens. The other programs out there, Medicare Shared Savings Program that many providers are in, aiming to get the same measures and data supports there. And Sam, I know you're new to the job. Just one last question for you. There are these national efforts to try to get to not only more aligned measure, but more aligned supporting data standards. Rebecca was talking about bulk fire, something that I never thought I would be talking about as a key element of healthcare transformation, but fast healthcare interoperability, report standards make it easier to pull data out of electronic records and actually compute those measures directly. TEFCA, data sharing. Can you say a little bit about how that fits into the longer term strategy here?
I can say what I know, which is that we have to monitor it, right? I think TEFCA, fire, and universal adoption of those things is the ideal, right? I think that's the state we want to get to. And it's not easy to get there, right? And so when will we be at a fully realized TEFCA fire state, and what steps do we need to take to get there is I think largely unknown at this point. And so we know that some large healthcare systems are in pilot state using bulk fire, exchanging data through a TEFCA-like framework. We know that some large HIE-like organizations or large EHR vendors are sort of stepping into that QHIN role and want to facilitate this kind of exchange. But we don't know how soon we'll get there. And we also know, and I think this, this goes back to something I said earlier, right? We're really talking at this point about large health systems, but often on Epic and often with large developer presences that can kind of get them there. But we're not talking about skilled nursing facilities. We're not talking about
diversity of providers that you're talking
Yeah,
about.
we're not talking about independent primary cares. There's a lot of runway, there's a lot of guardrails that need to be put in place till we get there. And so we want to be there to support as the HIE. There's other HIEs across the country that have already decided they'll be a QHIN, or they've decided that they'll sign on to a QHIN and be a sort of on-ramp for all their smaller providers to participate in TEFCA. I think, and some very smart people are advocating that we go in that direction. I think that, we have the privilege of taking a wait and see approach right now and kind of trying to fit ourselves into what North Carolina needs, what our provider constituents need in terms of bringing TEFCA online and making it real while still meeting everybody where they are. I think there's also, it's hard to go on about, but it's really important, and there's more will come on this. I'm looking at Jesse. I think to pivot as an HIE to something called a health data utility, where we're not just serving as the exchange of clinical records between clinicians, but doing more of the stuff that we just talked about, whether that's running quality measures, serving as a pass-through for Division of Public Health Systems, serving as an aggregator and referral system for social determinants of health or health-related social needs initiatives. So I think that we want to get there, but we really want to do it deliberately and with all our partners in public health and health services, education, and justice involved populations at the table, so we can do it right.
Well, so glad you're there, and really important reminder about how important these transformation collaborative efforts are to make progress. So thanks, Sam, for joining us. And Michelle, you've had a number of perspectives on all this work too. You've been a chief medical officer at a primary care medical home network. You've been working at a Medicaid health plan. Now you're Aetna's regional health plan director. As you said, you've seen a lot of different kinds of efforts to implement. Any further thoughts about how to build on the steps we've talked about here so far today?
Yeah, and first and foremost, most of my career was in primary care. And so I come with that heart and I come with that experience. And I mentioned I've seen transformation occur. And so I'm hopeful that the path and the roadmap that's been laid out here today to create a less fragmented, more coordinated healthcare system aligning is really important to create that. I think when we're all having different incentives and different measures, even within the same system, even within the same clinic, right? And Kristen and I were in that QHC world actually together. And, when you think about serving different kinds of populations as a provider, it's really difficult when you have all of these misaligned incentives. And so I think this is really important. But it's been a long conversation, right? We've been talking about this for a little bit of time. And so for me, it's really important that we also think about how do we get to those whole person improved outcomes. And you said, who stays up at night with data, right? I
That's
do.
you.
I'm the one, because it's all we talk about. How do we choose the right data sets? How do we get the data? How do we evaluate the data? And as we're especially looking to address disparities, because there isn't this common definition and because we're not all measuring it, and I do support multiple states now, it's really hard to evaluate and understand what are the interventions we need to do to actually get what I think we're all hoping to get to, which is improved health outcomes.
Yeah, and that means doing these steps towards more consistency, more alignment, so you can compare and measure how you're doing, but recognizing, Sam was saying, people are starting at different places. So how do we make that together go as quickly as possible? And Angelo, I've worked with you in a number of contexts, including in some national reform efforts, like around the physician-focused payment reform efforts at the federal level. How can addressing this challenge that we've heard about from Michelle? We've got people starting at different places, got a complex problem as you've talked about. Are we focusing on the right things to get there? What else can we do to make this all go faster, but still bring everybody along?
So as I think back about your graphic that describes what all the elements that you're trying to address, I think that captures things very well. And it highlights the comments I had about it being so complex. And so, and we do, most networks and for health systems, you mentioned health systems is where we're focusing mostly, have employed docs, which makes things a little easier, but most of them have a lot of independent docs, and we've got to figure out how to work with them. They're on a multitude of EMRs that don't connect, can't get data from. So I think that's a big barrier in how we provide good care to our patients that we've got to overcome. So I think the interoperability things are data definitions, governance of that data. I think those are things that we've got to work through. And again, I go back to, if we're really going to drive health equity, and I think about our Medicaid populations and things that we've done in the past, the real gains that we've gained with those populations have been in their local communities. It's not seeing them in the office and solving a gap or an immediate issue. It is identifying where they live, what social deficits are in those communities, what their access to food is, the sidewalks. We've also got to be able to integrate not just clinical data sets, but our demographic data sets and social data sets, and work with our county agencies and stuff to have a robust amount of data that we can look and identify where those communities are, that we can embed community health workers, and we can do those things that will drive performance. I think we're not going to get better than we are until we get to that point, and data is a place to start with that. So,
data and measures and as you know, the alignment effort and the state transformation collaborative are focusing on things like childhood immunization and blood pressure control, cardiovascular risk factors, diabetes control, common problems that, Angela, to your point, are best addressed in the community, that have all kinds of health related social needs that can complicate making progress. And while it's going to be hard to solve all of this, impossible to solve it all overnight, I hope we can help you sleep at night and that we're making progress step by step. So we stay up here for quite a while longer. Any quick final thoughts before we wrap up the panel? Other things that you'd like to see us focusing on, or last words or guidance for our audience today about how to help accelerate progress here? You covered a lot of it already.
Yeah, we did. I think for me, it really is, Betsy mentioned the whole person care. It's about keeping our eyes on the prize and remembering while we're doing this. And part of
That's
that
there,
is,
but these steps.
yeah, right. And we've got to get there. And I think there can be a parallel path. I'm hoping there's a parallel path, that we don't get stuck in the data, because I think that's this data conversation. We also want to move the needle forward and think about holistically what that community health looks like as a whole.
Yeah, and I think bring it back to the community. I mean, we're just so excited about the potential to take the Healthy Opportunities pilot statewide. We're really hopeful we will get there with CMS and be able to serve, members in a new and unique way in that whole person care model. So
I think it's leadership groups like this that just need to be persistent. You know, we need to continue to carry the message, continue to refine our processes, and we're allowing people like you to start moving things forward a step at a time.
All right, well, Angelo, Kristen, Michelle, and Sam and Cynthia, thank you all for joining us today. Thanks for all your effort with these state transformation collaborative approaches. Thank you so much.
Thank you.
It's an important and challenging topic. We have a few minutes now for comments and discussion. I'd like to go first here to Nick Minter, who's joining us from the Center for Medicare and Medicaid Innovation. Nick has been doing the work for CMMI on the Making Care primary models we just talked about, and as North Carolina has announced participating in along with many of the health plans, even beyond Medicaid. So Nick, you're kind of at the middle at the CMMI federal level on supporting these efforts to align measures and improve data. So how can you help us along here?
Well, first off, it's a pleasure to be here. It's incredible to see the work that's going on here. And I think our role in the Innovation Center, at least as far as the Making Care primary role, is really to sort of build upon a lot of the infrastructure and the progress that's already begun in North Carolina. I think we were very excited when we started to think about what we wanted to test in a new primary care transformation model. And the 2-second summary of what we're trying to do is to provide more financial resources, provide better data to align quality, and to be very clear with primary care about where we want to see value and to reward more for that for Medicare fee-for-service patients. And so when we started talking to potential states, North Carolina sort of came to the top as someone who already had a lot of broad alignment with the goals that we were seeking and commonality in some of the strategies, which I think we covered very well in that first panel. Quality alignment is incredibly important. Data sharing, data collection, those are areas that meaningfully remove provider burden. And that's something that we, in our 10 years of testing primary care transformation models, not in North Carolina, but in other areas, have seen are real impediments. And so, I think we're really heartened by the strategies that have started here. And one of the things that I've been very honest with our North Carolina Medicaid colleagues is we want to build upon the infrastructure that already exists and sort of, work and collaborate into, trying to drive progress forward to improve patient outcomes and frankly speaking, from our standpoint, to catch up to a lot of the additional investments that other payers may be making in primary care that Medicare fee-for-service hasn't been able to do or to make in the past. Some of what we see in the advanced medical home model, we're trying to bring some of those resources to contribute to those efforts. The only thing I wanted to, I know Sam had to run out early, but there was a lot of talk about data. I think the data piece is something that is really important to reflect on. We have always invested a lot on the Medicare side because when we test these models out, we go from sort of no access to data in Medicare fee-for-service to setting up a dashboard and trying to work with other payers in our past models to achieve some of the alignment that I think folks talked about at length here. And it is not an easy process always, but it has been really fruitful to pair the provision of data in a way that providers can use, to standardize that as much as possible, and then to provide some education so that, again, the folks who are receiving the data know how it's meant to be used. And what we found in some of our prior models is by working across payers that partner with us in the regions in which we've done this work, we're able to provide aggregated data sets in time. It's not something that happens instantly, and it certainly takes time, but it does make a huge difference when someone's able to see their entire patient panel in one place and understand sort of how those outcomes are, number one, affecting payment, which matters, but more importantly, affecting outcomes, which is what we really want to see improve for our patients. So we're really excited to work. I'm thrilled to be here to hear some of the discussion and really appreciate the time to talk about it.
Well, thanks for the comments, and it's nice to see the emphasis on, as much as people think about payment reform being important. Payment reform is a means to an end, and the end is really getting to better care and the kinds of things we've talked about here today, including data interoperability, sharing, reducing burden of getting the information you need and acting on it effectively and tracking progress. So important, really great to hear the CMI interest, not only in making progress nationally, but working with us right here to hopefully help lead the way. We are running a little bit behind, but we have a Slido up there. That's a place where you can submit questions. Also, any comments, things you'd like us to be taking into account in the further work at the State Transformation Collaborative. I've had time for maybe one question, comment. Yes, and we get a microphone right over there. And please tell us who you are.
Hi, my name is Sharon Williams, and I represent that crossbreed between healthcare and social care services. And there's a lot of conversation about data. Data is everything. Data is driving every single thing. What we're not talking about in terms of disparities is the disparity in how community-based organizations, those social care networks that healthcare is now starting to pay attention to, their lack of technology capacity is going to continue to be a problem as we press down from the federal and state Medicaid level to get more data out there, get more referrals, get more interoperability without investing in those community-based organizations' technology infrastructure. So wondering, with all the experts in the room, especially with the CMMI folks, what opportunity is there in North Carolina to look at some investment in community-based organizations' technology platforms?
Yeah, it's a great question. There are, and I think, Kristen, you talked about the Healthy Opportunities pilots, which are currently in 3 regions of the state. And you mind making one more comment on that if we can get the microphone down to you? So this is, as you know, since you've been working on all of this deeply, I know, a way to get some direct payments to the organizations that are helping when we screen for these health-related social needs. Okay, what do you do next? And how do you help close the loop and do that as efficiently as possible? Well, data is important for that, and a sustainable financial model. And that's certainly front and center to the work going on in the state.
Absolutely. No, we are looking really closely at that. I mean, we're really fortunate to have capacity building funds as part of our Healthy Opportunities pilot. And we are thinking about whether or not there are resources we need to distribute to community-based organizations to modernize or even just make more available technology to support the needs that you all have in this space. So that is, thank you for your comment. And that is very much part of the conversations we're actively having at North Carolina Medicaid. So
And definitely part of the current pilot evaluation, part of the Medicaid waiver renewal. It's in pretty advanced process right now, and going to be a big part of our work in the State Transformation Collaborative to assess and address health disparities too. So thank you very much. And again, thanks to everyone on the panel. Thanks to all you who are here. We're going to move on now to our next panel on looking ahead on advancing health equity through the North Carolina State Transformation Collaborative. We might hear some more about the same topic here. So that's back to Rebecca.
Right, so I'm going to tee up the next panel discussion here by just providing a little more context and kind of shifting now to upcoming work that we're going to be launching this summer, focused on improving health equity data to help drive reductions in health disparities and really leveraging the power of this North Carolina State Transformation Collaborative to do this in a multi-stakeholder way. So of course, health equity data aims to capture the experience of communities, including racial and ethnic minority groups, people with disabilities, lesbian, gay, bisexual, transgender, LGBTQ+ individuals, and folks for whom English is a second language, people living in rural areas. So, you know, a lot of sociodemographic, socioeconomic groups here. And gathering this data can really help us to document social and economic and equity factors driving them, and then really tailor both clinic-based, community-based, and population health-based interventions and policy interventions to help address some of those observed disparities. So, you know, as I mentioned previously, there's a lot of variation right now in how organizations are collecting, sharing, and using health equity data, which creates challenges for how we're able to direct resources and interventions to help address some of those identified health disparities. We do have great examples in our state for, and particularly the collection of race and ethnicity data. The state Medicaid program and North Carolina's COVID-19 vaccination program were recognized as having some of the most complete race and ethnicity data. North Carolina Medicaid having some of the most complete race and ethnicity data in the country. But we don't see that across all organizations. And so we really have some obstacles in making direct comparisons across population groups and organizations. So thinking about how alignment and standardization of health equity data can support efforts both within and across organizations to establish more coordinated and targeted interventions to address health disparities and overall health and well-being. And on the next slide, we just wanted to highlight, these things are happening in North Carolina, but also nationally. There's a lot of national momentum for improving health equity data, and in particular race and ethnicity language data and social drivers of health data. The Office of Management and Budget, for the first time since 1997, just updated the standards for collecting race and ethnicity data. So there's going to be changes coming down the pike for federal data collection reporting. On the health plan accreditation side, the National Committee for Quality Assurance, for example, has a health equity accreditation program, and that requires health plans to collect self-reported race and ethnicity data for up to 80% have self-reported race and ethnicity data. And certainly we're seeing a lot of focus on promoting social needs screening in federal payment models, including Medicare and Medicare Advantage as well. So a lot of momentum here to really build our data sets around health equity. And so we are excited to kind of leverage that momentum in North Carolina. So again, on the next slide, I touched on this earlier, but just want to center us again here on kind of the work that we have coming forward with this health equity data work group that we will be convening this summer. Starting again with establishing some guiding principles for equitable collection, sharing, and use of health equity data, and then exploring how, where should we start and what, in terms of the standardization. Should we start with the collection of race and ethnicity data? Should we focus on health-related social needs? I think this work group will help define kind of where we go next and prioritize initial steps. So I'm really excited to kind of kick off this discussion with our panel, they're going to be highlighting some early innovators for using health equity data to improve health and well-being in North Carolina, underscoring the importance of building community trust in data collection, sharing, and use, as well as kind of future priority areas for North Carolina State Transformation Collaborative Health Equity work. I think, we've heard in a lot of our conversations with folks that we recognize the importance of these data. We don't do a good job of collecting it across our organization, and we have the data and we don't know what to do with it. And so that's what I, really want to spend some time talking about with our panel today. So I'm going to start introducing folks, and you can come on up to the stage. Excited to have Jennifer Houlihan, who's the Vice President for Policy and Research Application, Enterprise Population Health at Advocate Health. Gabby Placencia, Dr. Gabby Placencia, who's a clinical associate at Duke Family Medicine and Community Health, as well as a National Clinician Scholar, Health Equity Policy and Primary Care Fellow at the Duke-Margolis Institute for Health Policy. Dr. Emma Sando, who's Deputy Director of Medicaid Policy at the North Carolina Department of Health and Human Services, and Cornell Wright, who's a Health Equity Advisor at General Dynamics Information Technology. So really excited to have you all here, and I'm going to come around and join you in a chair. I wanted to spend the first couple minutes here and have a question for all of you, and that is, in your organization or others, what are some noteworthy examples of how health equity data shapes practice or policy? And I'll maybe start with, go down the line.
And can you hear me okay?
Yeah.
Okay, great. Yeah, so we had a chance to talk in preparation for this. So a couple different ways. So the equity, now part of Advocate Health, which was Atrium, includes Wake Forest School of Medicine, a very robust equity governance structure with a new National Center for Health Equity. And through our School of Medicine, we also have the Maya Angelou Center for Health Equity. So those two play a role, one sort of leveraging the academic research piece, but also incredible community engagement, pastor networks, faith-based, other community-based initiatives. But then because of our National Center for Health Equity, that has really transpired into policies in our service lines. a more robust community social impact team, and then more importantly, resources. So of course, data is underpinning a lot of that, but really for those on the ground resources to be able to address that work. So a lot of investment, making sure that kind of through those policies, robust data inclusion policies, so very strong SDOH screening, and that equity piece too, that those are translating down into actual operational service line models, in addition to some of our pop health models. So ACO REACH is a great example. We have used that to be part of our health equity plan, to make sure we have robust social driver screening, new different types of care models, new community partnerships. And we see that translating into our Medicaid work, as well as all of our other payers. So I think it's kind of somewhat of a tension there too. We have robust policies all there. How do you dedicate resources? And certainly our payer models have been, and CMMI kind of on the forefront of that, but we see that translating into all of those.
Gabby, yeah.
I would say, I mean, there's a lot of different ways to answer this question, but I think that one of the ways, at least on the research side, that we've seen innovation in the use and collection of health equity data is thinking about ways to push health equity data further. So, you know, OMB recently just changed their federal reporting guidelines. And so they're going to have to be updates, right, to standardize across agencies, across institutions, how we're asking for this data and how we're collecting it. So might as well think now that we're going to be updating it, what is the next step outside of just what OMB is asking for, right? Research has shown that, especially for Latino and other immigrant populations, country of origin is a better way of collecting information than race, ethnicity, right? A lot of Latinos consider themselves Black Hispanic, white Hispanic, other Hispanic, and the majority of the Latinx population consider themselves other. They don't consider themselves white or Black, as shown by a more recent Pew Research Center survey. And so thinking through, and that's just the Latino population. The same thing happens with other immigrant groups, like consider Asian, the number of different countries that are considered under the Asian category. And so thinking through what are the next ways to push health equity data, what should we be collecting, and what is that information used for? And so I think that would be my second point to this is considering trust and who's actually asking for the data when collecting all of these surveys about health-related social needs, right? A lot of times researchers complain about missingness of data related to this, but the reason the data is missing when you actually talk to community members is, why am I going to fill this out? They're not going to do anything about it anyway. They've asked me this a million times and nothing has changed, right? Or, you know, they're going to use this against me is the other thing, a common fear of reporting, right? They're going to use this against me. It's going to get reported to ICE. So having the person collecting the data, you know, whether it's the person handing the survey or something like that, making sure that, for example, Medicare Primary has, you know, introduced the concept of, not introduced, but it's mentioned community health workers and using community health workers in clinical settings. What if we have community health workers be that extra touch point for race concordance, race ethnicity concordance, language, cultural concordance between, you know, our patient populations and, you know, our clinical and data infrastructure, because we know that there are not enough providers and, you know, clinical individuals that come from minoritized, marginalized populations. So these are, you know, ways to innovate and push health equity data further from kind of the research perspective, but also from as a family medicine physician, we say that health starts in the parking lot, right? So you walk into a clinic, nobody looks like you, nobody sounds like you. How are you going to feel in that clinical setting? Are you going to feel safe providing information, accurate information, and information that could actually help understand what the inequities are in the community? So those would be two examples.
For North Carolina Medicaid, we really focused our work around health equity in the summer of 2020. And we had a lot of wonderful ideas, but we strive for all of our policymaking to be evidence-based. And there are a couple of key examples of how we brought in data to make sure that what we thought we should move forward with was accurate, and we were expending our efforts in the directionality that would have the most effect. So first, we needed to make sure that we
had information, and we can't do it alone. So we have a partnership with a variety of different universities. For those that don't know, North Carolina Medicaid provides monthly claims data to Duke University, as well as that other school down the street. I'm speaking obviously of UNC Greensboro, and then we also go to UNC Chapel Hill. And we saw in the broader research communities, the NIH and others were requiring for any data that usage or research purposes that we had demographic data be reported to us. And we have really pushed a lot of our research partners to help us better understand what is going on with our Medicaid population and really drill down into the data to elicit more information about what the effect of our policies are. So now we've got a whole bunch of information, and what do we do with it? How do we measure disparities? So Sam is no longer here, but he helped drive our definition of the disparity so that it's common across the Medicaid program. And then we are able to use that to drive our quality strategy, to push our partners in our health plans and elsewhere towards common goals of reducing disparities that we see in our data. But as Betsy mentioned earlier, only a small portion of our lives are within the four walls of the health system and what you can see and measure in claims data. So we have been working tirelessly to improve our eligibility processes, because you can't make change and improve disparities until somebody's in the program. So that is first and foremost, but also I want to give a one more example, and it's from another university. We love working with every university that would like to work with us, but Medicaid is the only social welfare program in our country that has a requirement that after a person dies, if they've used certain services, that the state can go after their estate. And we know that there's a generational wealth transfer disparity within our country and our state in particular. And we partnered with a university researcher to really show that in the data and drive into what our policies around that policy of estate recovery, which is federally mandated, what we could do to make those changes. And so in 2023, we updated some of our policies, and that's an area where we continue to iterate to make sure that we're not inadvertently causing additional disparities in economics and other things that impact a person outside of the four walls of the healthcare system.
Well, I think this is a very interesting answer for me, because I've seen this play out on many fronts. So back in 2015, I became the third ever full-time executive director of the North Carolina Office of Minority Health and Health Disparities at NC STC. So we were able to usher in 2018, the first ever statewide health equity report, and seeing the importance of the data from that perspective. But also where I'm at now at General Dynamics Information Technology, the landscape is different, from state to state, from your partners. And so I'm in federal health side, and we work with all the federal health agencies. And there's something called the Executive Order 13985 that really allows us to really dive into that work of health equity and racial, ethnic disparities and other issues that we've seen really plague our country and our different states and our communities. And so for my job, my role is to help usher in the need for that data, put it into our proposals and growth opportunities, and also embed it within our organizational culture. About probably 2 or 3 weeks away from releasing our Advancing Health Equity Framework across our organization. And really, it's just really taken off. We just released a article through GDIT, and we can send it out to y'all, but it's talking about the correlations and connections between health equity and technology. and how that's important to look at it. And so the collection of the data is also a part of that, making sure that we're collecting the right things. And within our framework, we're also showing people how to take that data and generate the reports that's needed to, especially for our funders, our partners, and other people of interest who might need that data as well.
Yeah, that's wonderful. And I really appreciate all the different perspectives and sort of experiences that you're highlighting here and how you're able to emphasize the data collection, but then also how do we translate that into policy, into changes in clinical practice, into driving research, evidence-based policy and the like. So Jennifer, you touched on this briefly, but I wonder if you could share a little bit more for organizations who are interested in, how do we start emphasizing this within our own organizations, but kind of the policies, principles, tools that have enabled Advocate Health's efforts to collect and apply health equity data to inform clinical care and community collaborations.
Yeah, so I touched on kind of some of our high-level governance structure. I think one of the more straightforward policies is actually requiring it to be a goal for all of our healthcare leaders as well as service lines. And that can translate to financial, whether withholds, et cetera. But that has been one from a healthcare delivery system perspective. It's right there in terms of our mortality, readmissions, safety measures, giving parity to equity when it comes to how we think about quality from a very large delivery system. And so that then translates into scorecards at the absolute enterprise level, all the way down to what we call the market level. And they are really held, taken very seriously and reported up to the board. So that's one very tangible example. I think from the use aspect, where the SDOH screening data, I think that's gaining robustness, being able to systematically and have common definitions for race, ethnicity, language. We have different parts of the US now. We have the Midwest, we have the southern pieces. There are different cultures and races. And so creating some more standardization has been part of our process too. And as we've sort of aligned and built tools within our EMR to create that consistency, I think that has also allowed us to look at the data with clinical outcomes, with our community health needs assessment work. I think much of what Gabriella brought up is absolutely true in terms of different pockets and how do we bring in the innovation or the evidence that our researchers are gaining. So that's a piece of it too. But how that's translated today is, the data that we do have and fidelity and cleanliness is something that we continue to strive for. But, we're really trying to take that more granular. It is at the community level. What are the community partnerships we have? And then working with our practices on the ground in those communities, using the data to steer our efforts and or gain more resources to be able to do that work. And that's how we've translated it from that sort of high level governance all the way down to that level. And so our community engagement teams, working alongside our quality teams, our population health teams with our primary care practices, it's sort of been a much more multidisciplinary approach for us in that.
I think, those are really helpful examples and sort of how to integrate it. And I think maybe I'll come next to you, Emma, and picking up on that thread a little bit, because North Carolina Medicaid has been able to collect such complete race and ethnicity data. So what has enabled that at the department, and sort of what are you, as you think about, to Gabby's point, like where are we heading with health equity data? Kind of what do you see changing, and what are some next steps there?
Yeah, North Carolina should be very proud that we have been on the leading edge of having complete and accurate race ethnicity data, especially in comparison to other Medicaid programs across the country. But I think, unfortunately, a lot of the reason why is, if we can think back to the pre-pandemic era, it was very difficult to apply for Medicaid. And you needed to, most people did it in person.
When you're in person, you tend to provide more complete race and ethnicity data than filling out a form online typically. And so we see more complete race and ethnicity data, in part because the vast majority of our beneficiaries would apply in person. And the pandemic really changed the way in which people interact with the Medicaid program. We also improved a lot of our IT infrastructure and our online application to make it more user-friendly, which is great because we have been able to use those tools as part of Medicaid expansion and really get that out to more and more people, out of 458,000 individuals. But we need to learn those lessons from other states. A lot of other states refocused their efforts because they had more online applications for decades before us, or other forms of applying. In addition, it was also very hard to apply because only a certain populations were even eligible. And with Medicaid expansion, we have more and more populations and folks that are more used to utilizing online resources and whatnot. So we need to relearn from some of those other states to make sure that our data is accurate, as well as that demographic data is moving all the time. We've got the OMB standards. They haven't sort of translated that down into what Medicaid programs should do quite yet, but we're looking forward to some of that CMS guidance. And we're also looking forward to what else we can do to improve the application process. We learned a lot from COVID and the experience that we had with the vaccination program to make sure that we are capturing what people how people identify. But unfortunately, it is quite a lengthy process to change some of those bureaucratic applications and online systems.
Yeah, I think maybe I'll come next to you, Gabby, and so that we don't lose the thread here on the importance of thinking of new ways to collect the data and making sure as we make policy changes and infrastructure improvements that we don't lose that. If you could share some examples, both as a clinician and a health equity researcher. So how can health equity data support some of those targeted interventions and enable more equitable care?
Yeah, I mean, the example I brought up before of country of origin, when people identify as white, Black, Hispanic, Asian, et cetera, you're grouping people into these very large categories that don't necessarily reflect the underlying potentially genetic factors that put people at higher risk for disease. For example, someone who's Afro-Latino may have different genetic risk factors than someone who's white Latino for certain diseases. And so having country of origin, and this applies to my research focuses on Latino populations, but this applies to many other groups. And so having that more granular data of country of origin would not only help people self-identify more correctly as what they consider themselves as, and would improve also what we call street race or socially assigned race versus self-identified race ethnicity concordance, meaning when someone looks at me, what do they think I am based on race ethnicity versus what do I consider myself? That has large implications on mental health. So on physical health, mental health, and then also on data collection and reporting itself, accuracy of the data. And so that's an example of how from both the research side and on the clinical side, improving health equity data can actually improve outcomes. And I think the other thing that comes to mind from the research perspective and the innovation perspective is, we talk about the completeness of data, and North Carolina has been a great place to work because there's people like Emma and there's people at NC STC that are very open to kind of what is the research showing and what are ways that we can continue to improve. But I think that one of the next steps to go further in innovation is, we're talking about health disparities. How do we get to health equity, right? How do we find the people that we don't currently see in our data because they're not actually enrolled, right? And so how do we bring in, for, you know, to the example from the question before, data from CBOs, data from schools, data from the criminal justice system to see the total population and compare, okay, who's actually eligible and who's enrolled? I think that's the next step when we're talking about equity, instead of focusing on just disparities, which is where most of our focus is now.
Yeah, that's a great distinction between the two and not trying to conflate them. And yeah, absolutely. So Cornell, I might come to you actually for the last word, because I know we're running a little bit behind schedule. But I wanted to ask, so, you know, we're looking ahead to the North Carolina State Transformation Collaborative Health Equity Data Work Group this summer. What are some strategies that you've seen for building and maintaining community trust around health equity data, and where can some of these multi-stakeholder partnerships and alignment strategies help here?
Yeah, I think you really have to go back to some of the basics. Like there's a whole public health adage, nothing with, you know, about us without us kind of mantra. And then also like, you know, I wanted to pick up on something that Gabriella said that was important, is how people identify. And then sometimes we don't see ourselves in the option of what's available, whether it's just not there or you have to pick. So people look at me and they say, oh, he's a Black guy. Yeah, I am, but I'm also a part Lumbee Indian. So sometimes I don't have the checkbox, I have the radio button. So I have to be Black or do I want to be American Indian that day? And so it's, when we talk to our community partners, and during COVID, we created this historically marginalized population work group that was really diving in on a community level and taking that feedback and bringing it back to leadership at DHHS and how they see the world differently. We were able to fund those organizations. And there's so many lessons learned of things that worked really well during COVID, even on the data side of there were so many challenges of getting the data that we were able to put out there by race, ethnicity, but then we were able to show what we weren't able to collect. And I think that transparency helps build, earn, and sustain trust. And that's one of the biggest things. So when you're working with community organizations, whether it be your barbershops, your beauty salons, your faith communities, you know, anybody, school systems, that trust is the thing that really holds us back. There's historical trauma and triggers that we all face and have to deal with, but in certain communities, it's more impactful than other communities. And we also have to start really working with these communities when there's not a problem. And then also sharing resources, data, and information across the board, and then bringing them in, you know, not at the last minute to get a letter of support, but also just bringing them in and say, hey, look, this is the process, we need your help, and you know, how can we help you? So it's that bi-directional kind of connection that we have to have at every level.
A really critical piece, though. Well, thank you all so much for your time and contributions to this conversation. And we're looking forward to continuing the conversation through the North Carolina State Transformation Collaborative and continuing this important work. So thank you all.
And my thanks to the panel as well. We are running a little bit behind in some great discussion. We have a few minutes for comments, questions. I think we're gonna put up a Slido again. For those of you who are joining us online, if you have a comment or question that you want to send in, please do. And for those of you in the room, any topics you'd like to follow up on? Yes, Jessie, let me get a microphone, look over to her.
Thank you so much. Thank you to the panel. That was great to hear. So I'm Jessie Tenenbaum, former Chief Data Officer at DHHS, and hopefully future consulting with Sam on the HIE and bringing together data. And one thing we struggle with, or I struggle with, is this tension between, we did some things at DHHS where we were able to say, hey, we've got great demographic data in Medicaid. We don't have great demographic data in our NC Care 360 platform, but we can link those and then we can do better demographic profiling. So that was helpful for that. But there's a tension there of people give their data once. We want to make it efficient. We want to make it so we don't have to collect this, as someone said before, oh, it hasn't changed. Why are you asking me this again? So we want to integrate it, get that whole person thing, but we also don't want to make people feel like their data is just being used willy-nilly on the back end. And so I would love to hear from anyone, the panel or others, on that tension between having the data be used and freely moved, but feeling comfortable with how people are using data and who's using your data and being transparent about that.
Well, I know you've thought about that a lot too, but.
I just haven't found the
wanna answer
answer, so if anyone's got it.
So, do any of the panelists care to make a few remarks on that? Gabi?
Can you hear me? Oh, so I can speak to this based on my experience as a primary care physician and also as a researcher in primary care. Here, I often had patients, when I would tell them about NC Care 360, they'd be very excited about the idea of it. And then they would see the form, and the form said, your information is going to be collected and reported to other organizations. And I actually had several patients say, never mind, I don't want to be a part of this like database of information that is being shared to a lot of people. So I think the wording on the form was really confusing. And so, I had to kind of backtrack some of that and explain it in a better way for people to understand what it was for. And so from my experience as a researcher, creating those infographics, creating those like pictures and videos and things that are easily digestible to show this is being trusted with, this is being shared with trusted organizations. This is the list of organizations. This is the criteria for future organizations that we would potentially add on to this. And the reason we share this is so that when you provide information to one person, it gets shared with this other organization and gets continually updated in a network of people trying to help you, in a network of organizations trying to help you. So that there's this idea or this, fundamental trust of the network itself, not just one organization, because they might trust me as a primary care physician, but they think of it as kind of, these, vague ghost organizations it's going to go to. When you tell them specifically, it's going to go to the Department of Health, it's going to go to your school, it's going to go to, wherever else, then they kind of understand like, oh no, this is actually, the community-based organizations, for example, then they might be more willing to share that information. So, hopefully that helps.
Yeah, I think that's back to the importance of community engagement in all this work locally, here in Durham and rural parts of the state throughout. So thanks, Gabi, and thanks to the panel. We've had a few comments come in. One related to, as we talked from Mark Wynn, related to how a lot of the discussion today has been about clinician burnout, about kind of, hearing about incentives and things like that, rather than really connecting to why clinicians got into healthcare in the first place. And Mark was pointing out that if we can really make progress on these health disparities issues, understanding sources, tracking how we're doing on it, that might be a good way to reconnect with what the motivation was for a lot of us in improving health for everyone in our communities. But wish we had more time for all of this. It's been a great discussion. For our last segment today, I am very pleased to welcome another special guest from our federal partners in this effort at Center for Medicare and Medicaid Innovation, Kate Davidson, who is the director of the Learning and Diffusion Group. Have a seat, Kate, director of the Learning and Diffusion Group at CMMI. And Kate, in this job at Learning and Diffusion, that's kind of a complicated name, but I think it really means just helping make all of this go faster and at scale. So when it comes to figuring out how to learn from successes and extend them to other more diverse provider settings, communities, something we've touched on a lot here, when it comes to getting alignment across different payers and provider systems, supporting data, that's all in your office.
Yeah, I think that the work that we do in our group is extremely messy, to say it lightly. We get to take the really important and smart work that happens on the model team side as they're developing policy and think about what happens once it goes out the door. So once we move into implementation, all of the things that you guys have been talking about today, how do we start to anticipate what some of the ripple effects are? How do we support folks as they're thinking about taking a concept and transforming care within their system, and then scaling some of those learnings as well.
And you're talking about like getting out of the model framework and things that look good on paper. It's one of the words that I've tried to learn from a lot came from Mike Tyson, who once said, well, everybody's got a strategy until they get hit. So what I think you've seen as you get your get these models out in the real world is a lot of diversity and just a lot of differences in systems and capabilities out there. So in this past year, you all have done a lot of work to bring some new models forward, ones that are aiming, I think, at different groups of primary care providers, some in underserved communities, limited resources that haven't participated in the past, bringing in specialty care providers to do things like help coordinate with behavioral health care and primary care, or different kinds of specialty care, and then a lot of work on some of these alignment issues that we've talked about today. So can you say a little bit more about how that's going and what you're learning, what you're focusing on, in part from what you're hearing from places like North Carolina?
Absolutely. And it's so funny because the last time I was here was a little bit over a year ago. I think it was around February or March of 2023. And it was the day after we released our announcement of the Universal Foundation measure set. And that's always something you don't forget when you're about to do public speaking and you just had something announced and everybody's gonna have a lot of questions about, well, what does this actually mean as it plays out? And we were like, well, we're not sure yet, but we're gonna get there. And so we've made a lot of progress. In the past years, we've both kind of coalesced around this a framework for quality measures, but also using it as the threshold or like the bottom line for how we're going to be laying out measures across all of our lines of business. And so I'll just talk through a couple of examples of that. One is that we've built that into the Medicaid core measure set. And so really trying to promote where possible alignment across Medicare and Medicaid. We've built that into the marketplace quality rating system. And so really thinking about how we can partner with our folks over in CSIO and to bring this into the marketplace as well. We've built this into the primary care MIPS value pathway. So again, thinking about how we create that glide path for folks into APMs and making sure that there's some continuity across the quality measures that we're using where possible. And we're currently soliciting feedback on building this into the SSP program as well as into MA. And so there's a lot of work that we're doing across all of CMS in order to really create this threshold around quality measures. And this is going to continue to evolve. And there's been some publications about how kind of the next moves that we're thinking about for new measures where we can get to alignment. The other area I think that we've been focusing a lot on, Mark, is, as you know, and we've talked a lot about this, is really the specialty care strategy. And so, when the last time we were here, we were talking, we focused a lot on primary care, and we're still focused on primary care. We're actually moving into implementation. And so, as you all know, we'll be launching MCP here in July. But along with that, we've been thinking about how what the specialty care strategy looks like in relationship to those primary care models. And Angelo was talking earlier and he used the word complexity quite a bit. And so our strategy really has been, how do we think about existing primary care models or programs like SSP or like Making Care Primary, and understand the relationship between those models and the specialty care models. And so I would just point out, and I know we're tight on time, but I'll just quickly point out a couple of things. One is, in February, we started to release what we call shadow bundles for ACOs. And that is really summary level data around what it costs to provide care for specific conditions and or specific procedures. And we provide that information directly to ACOs, SSP ACOs and ACO Reach, so that they can begin to think about what it would look like to do a specific episode in that space. We recently also announced that we're going to be moving into doing more mandatory models in the specialty care space. And so we're really trying to ready the field as they're thinking about preparation for that. And the other place is in Making Care Primary as well. So really thinking about how we can leverage e-consults in that model, as well as in some of our ACO models, but ensuring that folks have the right kind of data in order to be able to refer to high quality specialists as well. So lots happening in that space. I could go on, I'm sure.
I'm sure you could. Just to connect it back to further to some of the work going on in North Carolina, we're glad you're on your regular travel schedule, and should add to that as one of the 4 so-called state transformation Information Collaborative States, working with CMMI, they're regular ongoing contact with Kate, the team at CMS and her federal collaborators. We talked today about some of the performance measure alignment and implementation that's going on here, starting with some important primary care measures, the data sharing and the diversity of healthcare organizations and community-based organizations that are part of this important effort, the efforts to identify and then track health disparities across groups that historically have not done nearly as well. Can you say a little bit more about connecting these priorities here to this big set of initiatives taking place with CMS leadership?
Yeah, there were two major themes that I think emerged from the conversation today that I wanted to talk about. One was data. The second was related to some of the commentary about CBOs and infrastructure as well. So I think that our strategy is very much aligned with what's happening here as it relates to data sharing and data infrastructure. There's a short, there's a medium, and there's a long-term strategy, and all of these things are playing out all at the same time. And so that is consistent with what Rebecca was saying. It's also consistent with what we heard from Sam and from Medicaid as well. And so I think we're all on the same page there. We have already started to utilize bulk FHIR and APIs to provide data directly to ACOs. There's a whole lot of reasons why that is important, but the exciting part is that we have the infrastructure there now in order to be able to do that. So, folks were pointing out that there's this existing issue with ensuring that smaller, more independent practices, safety net providers have access to be able to some of that infrastructure through their EHRs. And so that's where that medium to long-term plan is coming in as we're thinking about how we support some of that work in the future. But in the short term, we also, through MCP, through what I just talked about with the ACOs and the APIs, as well as some other models, we're planning on providing some of the smaller independent practices that don't have access to that data directly with some reports so that they can see their populations that's in the Medicare fee-for-service arena. So that's how we're working with folks. We also are going to be working very closely with Sam and with Medicaid and others here in the state of North Carolina to think about how we can partner with the HIEs and with others so that we have an aggregate data sharing strategy with the other payers in the state. So that's really exciting.
And you talked about connecting that as well with the community-based organizations and data sharing there. The North Carolina waiver, which has been piloted, expanded, hopefully statewide around paying directly for social services and the infrastructure for that is helpful. Any other learnings that you're seeing so far about integrating those community-based organizations and other providers or other partners in this effort who have also not been part of the data interoperability?
Yeah, I mean, I think the good news and the tough news for North Carolina is you guys are on the cutting edge of some of this around the data hubs and really thinking about how you pull in community-based organizations into this work directly. And so we're learning alongside of you all. Mark, you know this in your work with the Healthcare Payment Learning and Action Network. We've really tried to spotlight and understand what's happening for data hubs that are bringing community-based organizations together and how CMS can link in and support. We released some recommendations, probably like 6 or 8 months ago now, on data sharing in relationship with health equity and specifically community-based organizations. And so we're looking to North Carolina to learn, and it's actually, I have it written down in my office, questions about like, what are we seeing in this space and how do we elevate that? And that's the diffusion part of kind of the work that we do at the Innovation Center. I would just want to point out one other thing, which is that there was a question earlier about CBOs and the infrastructure piece. And, we very, very soon in the next couple of weeks will be announcing the release of an evaluation report. I think the final evaluation report for AHC, which is the Accountable Health Communities model. And so I won't reveal anything there, but what I will say is, we learned a lot from that model. We really learned a lot about screening for health-related social needs. And that is just one step that we've scaled across all of our models. Really, at the Innovation Center is this like requirement for screening. But then it's that connection with community-based organizations. And that's that next piece, is making sure that the infrastructure is there, making sure that the referrals are there, that there's this feedback loop that's happening across the community. And I think that's one of the things that's exciting about the Making Care Primary model, is because of the investment in the state-based approach, getting much more local, getting much more community-based. I think it gives us this opportunity for us to understand what the local needs are, what the local context is, as we're thinking about implementation and transformation.
Yeah, we certainly appreciate the open door and the ongoing ability to give feedback and provide some input on where additional CMMI efforts would be helpful. And you talked about how you're extending these efforts across programs, getting back to that alignment point. I guess I'd point out that in addition to that, there also are efforts at CMS to align not only with across the different CMMI models, whether you're participating in ACO REACH or Making Care Primary or others, but also the Medicare Shared Savings Program and steps in Medicare Advantage around the same kinds of ideas, measure alignment, consistent data sharing goals, and helping providers who are in different places move along together. So just to wrap up, any further advice for us as we try to bring together not just the state Medicaid health plans, but Medicare, we have participation from a range of commercial plans in the state in this multi-payer effort, providers who are serving people across all of these programs. Any final thoughts about what we should be thinking about in terms of what's coming from CMS in these areas related to alignment?
Yeah, I mean, I think that number one, we're thinking about how alignment requires flexibility, and it requires ongoing commitment to being at the table. And so these types of venues to have these conversations. So from our perspective, we continue to have a focus on health equity. I know that is something that is a focus here in North Carolina. We continue to put multi-payer alignment as one of the primary areas of focus for our model development. We have a goal of having 100% of our models have a multi-payer alignment strategy embedded within them. And that alignment doesn't happen overnight. It's not something we can turn on or off very quickly. It's something that really takes commitment and getting to the table over and over and over again, and saying that we're going to prioritize this as one of our focus areas. And so I think what we found that is really exciting here is just true partnership. Partnership, obviously, the Duke-Margolis Center, and so thank you for all of that, but also with the state Medicaid agency, and many of the payers here in North Carolina, and we're just really getting excited and about being able to launch, MCP here. I know we've got other models that are here as well, but continuing to forge a really important partnership here in the state. So thank you.
Well, Kate, thank you for sticking with it as well. Really appreciate your being back down here in North Carolina on this shared journey together. Thank you so much for being here today. We'll just stay there for one more minute. We are about done. As you've heard, there is a lot going on in this state, thanks to all of the different kinds of partnerships and perspectives represented in this room, and the many people who are with us online from across the state. Thank you all for joining us today. This is not an effort that comes together overnight. But what we've tried to do is identify some key themes where you all are telling us that we need to work together more to get more alignment in order to make faster progress on improving outcomes, on addressing health disparities, on reducing burden, and on increasing affordability of care. And we're going to keep doing that. So if you do have further questions or comments, let us know at Duke-Margolis. And please stay tuned with us for further updates about developments in this space, both here in the state and that we're working on nationally. We will continue to provide some of this technical support and efforts around addressing disparities around these efforts to move forward on alignment. We are going to be identifying some further shared commitment steps or statements that organizations can participate in to reinforce these areas where we feel like we can make important, concrete, near-term progress, and also more coming on what we're learning along the way. So this is not an area where we're getting everything right from the start, but it is an area where, thanks to having open channels like this within the state and with the federal government and with the evaluation efforts that are underway, we can make sure that we are making progress. So please stay tuned. And again, I want to thank all of you for being here today. I want to thank our Duke-Margolis team and our partners at DHHS for also a lot of work that went into making this day a success. And thanks in advance for what I hope is going to be an increasingly impactful journey together around our shared goals on whole person health.